So, good evening and welcome to our module, Introduction to Healthcare Law and Ethics. Last time we started the general introductory matters. We explored what healthcare law is, various medical law, health law. We look at all that. And we're looking at the relationship between healthcare law and ethics and some of the ethical precepts which have been explored by scholars and students in this particular area of the law. So tonight we want to continue. We want to continue that discussion and hope to finish it so that we are able to move to other topics next time. But just before we do that, I have posted on the class platform a link from BBC in relation to their brief lectures, which was held in the 80s by the Venerable Professor of English Medical Law, Sir Ian Kennedy, and he discussed a pertinent theme, which he termed obliging medicine. It's a beautiful lecture, and anybody who is interested in learning medical law or healthcare law, health law, I think is a very important starting general or public lecture for you to listen to. It was subsequently published as a book. So if you don't listen to that, the book on Maxing the Medicine is also available. And he tries to interrogate certain matters which were taken for granted as far as medicine, health profession, and also the phenomenon of disease or sickness is concerned. I'll leave it there because I have given you work to do. You're supposed to do a reflection paper and then submit it by next week. So having said that, we will continue from where we stopped the last time. And the last time, I think the last point was we tried to look at the justice in relation to government spending. And we made the point that when it comes to healthcare, justice refers to the equitable distribution of resources, access, and opportunities for health. Why equitable distribution? It is so, as we know, resources are finite, are limited. We do not have unlimited resources. Resources are limited. However, when it comes to needs, our wants, they are unlimited. And when it comes to health, for example, those who are in need of health resources are certainly more than the resources available to satisfy those needs. And particularly so when it comes to even the public sector, it becomes even more pertinent so that we ask, who are we giving access what resources as the case may be? And that is why in thinking of the justice, how to ensure justice as far as the healthcare is concerned, Rawls discussion or how he explained justice. For example, becomes a useful reference point or framework. So in that respect, we can refer to principles of distributive justice, which concern itself of how benefits, burdens shared in society. How do we share benefits and burdens in society so as to achieve some equity, some fairness? So we have noted in our other course, Health and Human Rights, Article 12 of the International Covenant on Economic, Social and Cultural Rights, as well as the Constitution of the World Health Organization, that when we talk about health, we are talking about a fundamental right which imposes obligation on governments to ensure fair access healthcare for all. So how do we navigate that? Well, some philosophical and ethical pointers may assist us. So Rawls, for example, talk about the difference principle, and in that regard, he will say that we should give priority to least advantaged members of society in order to achieve fairness. So that if we are thinking of who to favor, who to maybe allowed to join the queue for quite some time, then Ross will tell us that we should give priority to those who are least advantaged members of society. And in that respect, it is a view of John Rawls that social and economic inequalities are permissible only if they work to the greatest benefit of the least advantaged members of society. That is to say that we shouldn't overburden the least advantaged members of society so much. And that is why it's telling us that the only way in which we can tolerate social and economic inequality is where they do not impose too much burden on least advantaged members of society. And that is possible only within a system which also secures basic liberties and fair equality of opportunity. So how does this work out in practice? So practically, this will come to institutions allowing incentives or higher rewards. Maybe, for example, we have specialists, and then you decide to probably pay them more. Only when paying specialists more, for example, raise the floor, and floor in what sense? That is, improve the position of those worse off compared with any more equal alternative. So if you want to pay the specialist more, there's nothing wrong, but make sure that in doing so, it's not going to disadvantage those on the lower ladder, as it were. So Russian or Ross principle in this respect embodies a maximum rule for basic institutions. What is that? That choose arrangement that maximize the minimum share of primary goods. So the primary goods like rights, opportunities, income, and other social base of self-respect, should go for arrangements which would ensure that you make most of it, even if everybody is going to get a small share thereof. And it's not so much about maximizing the aggregate welfare. What each individual gets is as important as the total effect on the community. So if you are interested in knowing more about Russian views, there's an interesting book, a medium size fat book, A Theory of Justice, which he has authored. I have a copy on my shelf. If you are interested in reading it, you can read more about that. We also have Norman Daniels. So what we are trying to do, we are trying to explore how we achieve justice when it comes to healthcare with respect to government spending. And very soon, I'll be taking your mind, particularly so as our finance minister is going to read the budget, I think, for the next financial or fiscal year. So Norman tries to build upon Rawls' ideas and makes the point that fair equality of opportunity requires equitable access to healthcare. So he's done a nice work, that's health, meeting health needs fairly. So if you are interested in reading it, you can also access that. So basically, Norman, in building upon Rawls' idea of justice as fairness, seeks to apply it specifically to health. Rawls was not only speaking about health, but Norman Daniel tried to mobilize the ideas of Rawls with respect to justice and how it can be applied to the context of health. And in that respect, Daniels makes the argument that because good health is essential for individuals to exercise their opportunities in life, access to healthcare must be distributed equitably. So if trying to remind us that if all of us take the view that, yes, we all need good health in order about normal life functions and enhance the quality of life, in that case, it is important for all of us to get fair or equitable access to healthcare. Of course, being human beings, we will fall sick, or the integrity of our health may be compromised in one way or the other. And when it does happen, we need help. We need healthcare. So there should be equitable access to healthcare. So he did another work, what we call the just health, meeting health needs fairly, as we mentioned already. And he will make the point that societies have a moral obligation to ensure that health inequalities do not arise from unjust social conditions. So that is to say that we have to pay attention to social conditions so as not to let it become bad to the point of causing injustice, inequality when it comes to people getting health care, as it were. So to achieve fairness, he proposes that public decisions about allocating healthcare resources should follow transparent and accountable procedures. So there should be transparency when it comes to the various framework which have been put out there for letting people get a share of healthcare resources. And again, there should be accountability to ensure that when people feel aggrieved that they've been cheated in terms of not getting the fair share of healthcare resources, they could seek remedy. And those who are responsible for that would also be made to face consequences or sanctions for so doing. So he did an article with James Sabin, and Daniel's article, James Sabin, titled what he called accountability for reasonableness. And by accountability for reasonableness, they meant rationing and priority. That the rationing and priority setting must be open to public scrutiny based on reasons that fair-minded citizens can accept and subject to revision and enforcement. So, for example, when you come to our country, Ghana, when it comes to some critical healthcare intervention, either some other vaccination or management for certain conditions, who certainly are expensive and may not be affordable to the average patient. What mechanism do we put in place to ensure that there will be some reasonable fairness, and there will also be public scrutiny, so that people will feel that the system is fair and it does not cheat anyone, as it were. So I will encourage you, if you are interested, to download Accountability for Reasonableness, Certain Limits Fairly, published by the Oxford University, and read more about these ideas by which Daniels and Sabins seek to connect justice in health to fair equality of opportunity, so that everyone has a genuine chance to live a healthy life and participate fully in society. And in fact, if we come to a part of the world, it may be so sad in the sense that are not living meaningful life just because of some basic health conditions, which does not even require much, but just because resources have not properly distributed, resources have been skewed. So much money is put in certain expensive health management or diagnosis or treatment, so much so that the masses of people who need just a little amount of resources in order to get a cure, in order to come out of certain health conditions, are deprived of such critical intervention. I'll come to you in the course of time of this lecture and take your view, especially those of you who are actually on the ground practicing. And with respect to government spending and its relationship with justice in the healthcare, we would like to make the point that in terms of how much of the national cake is put into healthcare, is very much a reflection of societal values and moral priorities. So, just before we ended the last class, I asked a question. Will you say that government should put more money in preventive healthcare as opposed to preventive healthcare. And interesting views came from you. I'm sure you've reflected on it. So, for example, when it comes to mental health, will you say that more resources should be given to mental health? Or we should rather give more resources to preventive care as a way of showing commitment to long-term social welfare? So when we mention mental health, for example, a lot of people say that, but these smart people, why should we put our money there? Forgetting that the people you are calling mad, they are not the only mental health patient. And all of us, the one way or the other, suffer from one form of what? Mental health. Except that ours, maybe, ours have not graduated up to the point where other people can call us smart people. Now, if you go to UK, I've mentioned it in the last class that there's a body you call the NICE, National Institute for Healthcare and Care Excellence. It used to be called the National Institute for Health and Clinical Excellence. It comes out with a manual and various documents to guide how things are done in the various NHS-funded institution. And in this health technology evaluation, the 2022 manual, with the issue, they sought to embody principles which would ensure the cost effectiveness and fairness. And the specific prescriptions in that document are not just taken from abstraction, they are evidence-based. Evidence-based in the sense that they conduct research from what actually goes on in the health industry and patient experience and so many other things. And based upon that, they come out with recommendations. So we'll just look at a few cases which reflect or illustrate ethical and legal tension when it comes to public spending in healthcare. So in the UK, for example, we have S Party B, R against the Cambridge Health Authority, S Party B, and that case brought up a situation in which the court upheld a refusal to fund experimental treatment for a child. And the court was saying that, yes, painful decision must be made under finite budgets. Where you have a treatment which has not gone through full clinical trials for approval to be given, but then maybe from initial work on it, some hope is given that it could give some beneficial outcome for certain patients in certain situations. So this was the situation where this particular patient, pediatric patient, wanted to benefit from it. And because it's not going through the full and then become like a part of what is funded by the National Health Service or the NHS, when a request was made that the Cambridge Health Authority should provide funding and then they refused it, a challenge was made to their decision in the court, and the court agreed with the decision by the Cambridge Health Authority to refuse the funding on the basis that they had a very limited resources. The budget was tight, and for that matter, they could not, spend it on experimental treatments. Of course, some of these decisions, sometimes they are not all the time consistent. As, for example, in the R against a Sweden NHS primary care treatment. The court found that denying access to a cancer drug without a rational policy basis was unlawful. So, in one case, 1995 decision, the court is saying that yes, there's nothing wrong if the health authority turns down a request for funding for experimental treatment. And later on, about 10 years or so later, another court is saying that where a person needed cancer drug and same could not be given to the person, it was just not enough to deny the person. There should be a rational policy, a policy which can stand up. You know, if you've done what you call administrative law, there's something called the Wednesday reasonableness, and also the principles for judicial review, propounded in the case like the Council for Civil Service Union, and so on, the principle of irrationality. So where you have like a policy, it should stand up to rational scrutiny, reasonableness, and tests, so that if you say that this patient cannot be funded in terms of this drug which he or she needs, we can evaluate your decision on basis of this policy, so as to be sure whether you are being arbitrary or you are not being arbitrary. So, for example, if this were to be the case in Ghana, in Ghana, we have Article 296 of the Constitution, which talks about discretionary power, and also Article 23 of administrative justice. So if you are dealing with, like, let's say that the public health sector, and assuming situations like this come up, we need to have some predetermined rules or guidelines or policy which you have announced as guiding how you are going to make decisions with respect to maybe requests for access to certain treatment and so on. And if you don't do that, then you could be accused of being arbitrary, as it were. But the point to note from some of these English cases relating to allocation of healthcare seems to be that, yes, the courts, as a general rule, will show deference or respect to administrative discretion or the use of discretionary power by administrators. That notwithstanding, the courts would always ensure that there's no arbitrariness and rather have consistency and rational justification. After all, the courts are there to ensure justice. And how can we ensure justice where we actually pretend over arbitrariness? The courts are not there to do that. Okay, so let's have a little bit of a direction. Come back to what we talked about last time. Should government prioritize preventive care, such as vaccination, or curative interventions, such as advanced surgeries? Yes. So assuming the government is taking your view, as it's getting ready to put its budget for next fiscal year together, that it would like to know whether more emphasis should be given to preventive care, such as vaccination, or curative intervention, such as advanced surgeries. What will be your take? What will be your advice? Yes, put up your hand and then we can call you. We have limited time. We are taking only 2 students. Then move on. Are you with me? Okay, Richard Assam first, and then Rebecca Kuma. Yes, we have two now. Good. Richard Assam and then Rebecca Kuma.
Okay, so thank you. To ask all. So I think government should invest more in the preventive care, such as the above mentioned, vaccination and other things, rather than curative interventions. Why do I say this? Now, at the formative stage, if the necessary interventions and policies are formulated to be able to prevent, as it were, the occurrence of these conditions, chances are that they will not, many more people will not get infected, and there will be no need for us to be effective for prevention than curative. If you look at the investment that government will put into prevention, it will not be as compared to what will go into curative. And because it will benefit everybody, I am coming from a utilitarian view that as many more people will indirectly from the preventive interventions, my best bet is that we put our money where our heart is, and that is in the prevention. Thank you.
Well, thank you, Rebecca.
Yes, so good evening.
Good evening.
Please, I will think of the fact that government must actually find balance because looking at our current disease trend, I think little, or I wouldn't say no, but little attention have been given to most of our non-communicable diseases. Things that actually complicate into conditions that actually would rather require much more funding to manage. And we have such conditions with us now that need not to be prevented, but they are already happening with complications that need to be managed. So government will actually have to find balance, do a lot of trend analysis and see where to actually strike the balance, because we have a lot of childhood cancers, adult kidney diseases with us now. And because we are not complicated diabetic conditions, because we are not focusing on managing the conditions that they have actually come to stay, the complications are getting worse off. So whilst we are echoing on prevention, we should also find balance in where we can put in some funding or support for people who are already living with the conditions to minimize the complications and the rehabilitation costs that come along with it. Thank you.
All right, thank you very much. Okay, we were taking two, but since Mike and is let's take Mike. Yeah, Mike, let's take you.
I just want to, but Rebecca, most of the things I wanted to say, because I wanted to say that a balance should be found at, and then in finding that balance, the data, the disease situation should influence where to spend more.
All right.
And I think she said exactly that.
All right.
So that's all that was.
All right, thank you very much. So our next question, is it ethically defensible for public funds to cover experimental or high-cost life-saving treatments with uncertain outcomes. So let's pay attention. We want to find out if you have a situation where the particular treatment is experimental in the sense that it's still going through clinicals, if not exhausted, the clinical trial cycles and various approvals. Must we put more resources there? Is it right? Is it ethical? Especially having regard to public funds, which is limited. And similarly, is it ethical for us to put more resources in high-cost life-saving treatments where the outcomes are not certain? The outcomes are not certain in terms of whether it will be beneficial or not beneficial for the patient. What do you think? Yes, I want two students, one male, one female. We have limited time, so we need to hurry up, please. Oh, is it the same people who are talking all the time? I want those who have not spoken. Okay, Richard, since nobody wants to speak, let's take you, please. Thank you. Richard.
Okay, so thank you, Doc. So for me, I think in situations like this, there are two things I will use to guide whether or not such expenditure should be made or not to be made. One is we are looking at whether we have the financial muscle to be able to, as it were, venture into this worthy, if you like, venture, and what will happen to other important sector of the economy. Will they all come aground because of we wanting to, as it were, invest in these things? What fraction of our population are in interventions going to help? So if it is a certain minority, I think it will not work the spending. Again, I am coming from a utilitarian view. I'm looking at the group interest, the larger majority. That is what I am looking at. So when we look at all of these things, then the ethical consideration is telling us that it is a minority. And so we can just stay with the status quo. I think we will have to stay with it without investing. But if we look at the indicators and they appeal to a certain fraction of our population, then it is good we also invest in that direction. Thank you.
Thank you. The person. Yes, let's take Busa and then we take Apikeno. Then we are done. We move on to next. Yes. Busa first and then Apikeno.
Yeah, Prof. Thanks, David. This is Apikeno.
Yes.
So I believe that we, as a people, as you are developing, we need to have things that are very, and there will be things that are very particular or peculiar to us as a people or as a group. So if we channel such resources into such experimental treatments, we may know that with our physiology, this is what is good for us. Most of the time, most of these treatments try out elsewhere, and it trickles down to us. So if we take the step and we do it our best, we try it on our system, on our body system, we can tell that this is working for us or this is not working for us. So I believe that once we channel our resources into such experiment in the larger good and for the near future, we may know that these are the benefits and these are disadvantages going forward. So we may tweak it ahead so that in future, what it can be refined better to serve the larger population. Thank you.
Thank you. Yeah, so Abusa. Okay, good. So we move on to the next issue. Should cosmetic or lifestyle procedures ever be publicly funded? So by cosmetic, or lifestyle procedure, such like maybe somebody will say that, oh, especially ladies, maybe my boobs, my breasts are small, I want to make it big. My buttocks don't like the shape, I want it to be big in a certain shape. My nose, I don't like my nose, I want it to be this. So, doctors will tell us there are a lot of surgical procedures which can achieve all these expectations. So if we have like a public funded healthcare, will you consider it appropriate to channel public funds towards such cosmetic or lifestyle procedure? Or you will say that if you are to do that, you are probably introducing a moral bias in how we define a need. So what is considered a health need for someone will say that may be different from another, so that if a person thinks that I have a particular type of body and all the time I'm thinking about it, it affects my mental health and well-being. So for me, that is a legitimate need, and it's not just something luxurious or as it were unnecessary. What do you think? Yes, I need one or two responses and I'll move on. Let's see. The whose hands are up. Yeah, this, okay. Okay, so let's take Sule first and then Rebecca. Rewan, yes, let's hear you.
Yes, sir. So, sir, I'm of the view that it is not really ethical, in as much as people may have different definitions of need. I mean, there is always a hierarchy of needs, starting from probably life-threatening, conditions, life-saving conditions going on. So in a developing country like ours, where resources are actually in not so much available, we tend to, I think it would be unethical to prioritize some of these lifestyle procedures over the needs. As much as possible, we'll always have the poor, the needy amongst us. And I don't think they've even gotten there yet. So I think it will be morally reprehensible to, will be the needs of what I would call probably the bourgeois, and then they should have the money and resources to fund that outside the public coffers. Thank you.
Right, thank you. Rebecca?
Yes, Doc.
Yes.
Okay, Doc. So, like you, like it's clearly stated in the statement, need and in inverted commas. So, a need that one cannot do without. And then, so some of these lifestyle procedures are basically wants, if I will put it that way. So, for a health need, unless the situation becomes such that healthcare professionals can actually classify it under a healthcare need for the person to go through such a procedure, then I don't think it should be publicly funded, unless the healthcare professionals are able to classify that procedure, though it may be a cosmetic procedure, but if it is carefully classified under a health need for the client, then we can consider public funding. Otherwise, once they are personal wants, people should be able to fund their cosmetic procedures,
right,
how they want their bodies to look like.
Right.
Thank you.
Right. Thank you, Rebecca. Mhm. All right. So another thing we like to touch on as part of our general introduction is inequity for the insured. Because we are talking about justice in access to healthcare. And if you look at the aspect of government spending, but another thing worth observing from the literature is that we encounter major injustice in healthcare due to disparities between insured and uninsured population. Of course, this insurance, you go to the US, for example, this will really come more close to you. Over there, if you don't have like the health insurance, your life could be really miserable. You could even die when you get certain health conditions. Well, here in Ghana, we have the National Health Insurance Authority. We'll see a few more things about it pretty soon. But in terms of its reach, and even those who are on it for certain health conditions, you go to the facilities and then you are told that you don't have this drug or you don't have that, you don't have that. And it is not also the case that if you go and buy it from another place, the National Health Insurance Authority is going to refund the money to you. As far as I'm aware, it doesn't work that way, but those of you on the ground may actually share there's a contrary information to what I am thinking. So those with insurance often receive preferential treatment, especially in our part of the world. If you go to the hospitals, those with the private health insurance, the Acacia and the rest, they are given better attention than those who are probably just enjoying the public funded system, as it were. Or even those who are uninsured, they certainly encounter systemic barriers or delays, or sometimes catastrophic costs. If you're a private patient, you go and basic diagnosis procedures, so much bill slap in your face before you even come to get the various treatment and whatever medication that the doctor will prescribe for you. And certainly, these inequities challenge the ethical principles of all fairness, and equality of access, and we need to be mindful of that. So a more concrete way to illustrate this inequity we are talking about, priority of treatment, as we've talked about, that insured patients will get faster access to specialists or elective procedures. And those of you in practice who can testify, even in Ghana, those who have companies subscribing to special insurance package, when those patients go to the facilities, the level of treatment and the specialist access they get. Again, the inequality comes out in the form of financial inclusion. Uninsured patients are denied necessary treatments, or they may face overwhelming out-of-pocket expenses. And we encounter it all the time. You go to some facilities, and by the time you finish the few procedures, hoping sum of money will have gone out of your skin. Now, the other thing also has to do with the clash between moral hazard and moral obligation, in the sense that if you have a private insurance, no human being, a psychological thing that because I'm paying the premium, let me go and assess service under it. Otherwise, I'm losing. So we are going to have overuse because of the thinking that, well, private insurance, the premium is paid anyway. So if it's paid, why don't I make use of it? In the same vein, where you have a public health system where the funding is really low, it can also lead to rationing of essential care. And I have witnessed this, especially in the UK. You go to the UK, because they have this NHS, okay? You request for a treatment or consultation, and you have to join the queue. And they've even introduced a system where you have to go to the NHS portal, and you log in, and you have to do a whole lot of self-diagnosis, taking a lot of buses. And where in the end, maybe the system will consider you as needing attention. You still have to join a queue. But in sometimes where a doctor has actually recommended a particular procedure, you may not get it, and you may have to join a queue. That is another dangerous thing. We have seen the case of Subramani against the Minister of Health when we're discussing health and human rights. So we will not belabor it. Just trying to cite it to illustrate this inequity in health care in terms of access. So if you remember Subramani against the Minister of Health, KwaZulu-Natal, the South Africa Constitutional Court gave an important decision to the effect that denying dialysis to a terminally ill patient due to scarce resources did not breach the constitutional rights, like under South Africa Constitution, to guarantee health care or health. And the court has a view that the right to health care is subject to progressive realization. Progressive realization means that in terms of meeting the obligation, is not one-off because it's resource dependent. So the court will need to measure or evaluate what you have done vis-a-vis the obligation and your means. And then the court to find out whether, based upon the resources and the means, you have done enough in terms of meeting that obligation. And that is why the court said that, yes, you have regard to the circumstances. You can have a dialysis machine for all those who need it. So therefore, if a particular patient did not get it, it should not be construed as a denier of the right to health. Well, if you look at the literature, there's a similar case from Canada, Charlie against Quebec. And there, the courts actually struck down laws which prohibited private health insurance for medically necessary services. And the court of the view that excessive public delays infringe the right to life and security of person. So that is, but again, these are two different jurisdictions. But if in the same jurisdiction, it will always turn upon the resources at stake. So that is what we should keep in mind. And as you can see, the two contrasting decisions that you look at the Subramani and also the Chudua from the Canada one. The Subramani one will be looking at collective resource constraints. If you look at the entire picture, can we really say that by refusing or by not meeting this particular patient requests for dialysis, have we be compared to him as breaching his right to health? The South Africa Constitutional Court said, no, that is not it. But then, if you look at the Quebec case, the Canada one, you notice that the individual right was elevated over and above the collective, as it were. Now, as I indicated, we have the National Health Insurance Scheme, and before the National Health Insurance Scheme was introduced in 2003, during President Kufuor's rule, we used to have what we call the cash and carry system. So the cash and carry system simply meant that if you went to hospital and you could not pay whatever was needed, you didn't get treatment. As the Nigerians would say, no, for joke, cash na hand, bag na ground. No pay, no service, as it were. So that used to be the situation. And then we ushered in this, if you like, a universal public healthcare as a massive through the National Health Insurance Scheme. And for now, there's some sort of financial protection, financial risk protection, as it were, as far as basic health care services are concerned. People have done a lot of research concerning the effectiveness and the coverage of the National Health Insurance. Our current discussion is actually unable to engage in those that I mentioned, but I'm sure in your other courses you are doing health funding. So I'm sure that you have encountered some of these matters, but it's worth looking at the literature, what the picture has been, as far as the coverage of the health insurance is concerned, its effectiveness. So if you look at the website of the National Health Insurance, the last time I checked, the information available indicate that about 68.6% of the population is either covered by the National Health Insurance Scheme or private health insurance scheme. I don't know how accurate it is, but that is the information I get from the website. And membership is annual and renewable. Is this still the case? Must you renew your membership every year or once?
Yes, Lord, it's annually.
Annually, okay. We have exemption, children who are under 18 years and persons who are 70 years and above, and pregnant women and extremely poor are given it exemption as far as the premium payment is concerned. What is the current premium rate? Like how much is supposed to be paid? National insurance,
Yes.
how much?
I think if yes, they contribute, it's about 20 cedis.
Okay.
Yes.
Is it for a month or a year?
A year.
Oh, then it's not expensive.
No, not at all.
It's not expensive.
No, even the renewal now is free for slate contributors. It's free for slate contributors, and those who are not contributed between 18 years and 60 years are paying 23 Ghana cedis yearly.
Oh, then that's
if you are below 18 and above 60 years, you pay less than that.
Oh, okay.
6 cedis.
All right.
Yeah,
That's
they pay 6 cedis.
okay. Okay, then that is good.
Including the pensioners, once you are a SMIT something, it's free.
Okay, that's good.
It just renews automatically for you.
That's good. But I learned of something, I don't know if it is true, that because of the delay in the National Health Insurance Authority releasing payments to the providers, when patients go there, you have to pay. Otherwise, you receive a very poor treatment or you are not treated at all. Is it true?
No, please. What it is the supply of the medications that are available. So sometimes it will surprise you that you even go to a tertiary institution and they'll tell you to go and buy para outside because they don't have it. And they don't want to commit themselves by selling paracetamol to you. And then you go out there saying that this hospital charged me for paracetamol, even though I am with health insurance. So in order to also stay out of trouble, they will ask you to go and buy it outside. So if it's not available, it's not available.
Right. Thank you. Yeah, so we've talked about the...
Prof, when I read your earlier slide, when you mentioned that insured clients are usually given... I wouldn't get the actual same words, but usually given
preferential treatment. Yes.
I was a bit
worried.
Like, yes, because actually on the ground, some of these things are not really the case.
Okay.
So sometimes, especially for you to see a specialist and all that, most of the non-insured clients who are rather paying the specialist consultations fees are rather sometimes given
right
and all that.
Right.
Yes.
Right. Thank you. Yeah, I think we've discussed it. Let's move on with time. You can go to National Health Insurance website and read more about these matters. Okay, let's take one of these issues before we move on. What are the ethical and legal responsibilities of healthcare system to mitigate inequities between insured and uninsured patients? So let's use that as an example. If you have someone who is not on the national health insurance, if we have regard to our healthcare system, either the public or private, do we have measures or mechanism which seeks to protect these uninsured patients so that they don't get worse off as far as healthcare is concerned? Yes. Anybody who can help us? In other words, if you are not insured, right? You are not an insured patient, and you need care, you need treatment. Are there any measures to help you?
No, currently I wouldn't say there are measures. It's limited.
Right.
Because you would have to pay from your consultation to your lab services, unless of course it's an maybe accident situations or emergencies that the facility will start caring for you while they ask relatives to go and continue making payments or go and pay consultation. But because you are in an emergency situation, the facility will continue to manage you, but you still have to pay. But for you to walk up, like enter a facility without insurance and without money, just walk into the health facility and access healthcare, you have to pay.
Right. Right. Thank you. Mavis, your hand is up.
Hello, Doctor.
Okay. Yes.
This is Musa.
Musa, okay.
Yeah, I happen to work in one of the church facilities, and that is the Presbyterian.
Right.
And then we have a policy of poor and sick. So if you walk in uninsured and then based on our criteria, you are qualified to be poor and sick, we go ahead to treat you whether you are insured or non-insured. And if you are going to be an inpatient too, and you are not even qualified for poor and sick, the church facility states that we should go ahead, once you are inpatient, we should go ahead and take care of your health needs, irrespective of you not being able to pay for your medical costs. Then when you get well, so these are the measures we put in place at our place to handle the need of those who are not insured.
Okay. Thank you. Let's say the second question. Should courts intervene in rationing decisions, or should these remain prerogative of policymakers? In other words, when it comes to giving access to healthcare and so on, and certain treatments, must the court come in where a person is aggrieved by a decision refusing or limiting his access to particular healthcare? Or you think that this is a matter which should be out of the supervision of the courts, and it should just be a prerogative of policymakers? What do you think? And be guided by some of the cases that we've looked at. Yes, what do you think? So that do you think that maybe if somebody, you look at the National Health Insurance, I think they have a list of treatments or the level of care that they provide. I stand to be corrected by practitioners on the ground, but if that is the case, and let's suppose that a patient needed a particular care or treatment, but he or she is told that we are sorry, the National Health Insurance Scheme does not provide this type of treatment or this kind of procedure. And the person say that, no, I have to be given. So the person takes the National Health Insurance or a particular facility to court. Do you think that is a matter which should involve the court, or this type of matters should not involve the court? So that is the crux of the question. What do you think?
Yes, this is Adline.
Adline, yes.
Yes, so even in the first place, when we talk about insurance, it's really mostly just effective in the government institutions. The private institutions or the private healthcares, systems, they also reserve the right whether to accept national health insurance or not. So if the court cannot come in because there is no national rule or standard, you should charge this amount per consultation. So if you don't have insurance, national health insurance, and you go to maybe all district hospitals, the amount you pay for consultation may cut across. Or there might be facilities that would like to add something small to generate funds. Those ones can be regulated, but you can't force it on the private ones. Because even if you talk about data collection, there's a general this thing called DIMS. For private facilities to enter their data so that those who are doing surveillance can get the data for it to be used for policy making and then other interventions. It's difficult to get them to do it. So if it is insurance, and it is speculated insurance that we cover, let me use dialysis. Initially, it was 3 sessions, chronic people, but now it's been extended to 8 sessions only. And that 8 session is limited to the facility where you start it. So if the insurance states that you are entitled to only 8 sessions, after 8 sessions, if you need more, the hospital is not responsible for giving you more. Neither is the health insurance policy or the authority also responsible, or they are breaching their contracts by not offering you. The best the facilities do is to solicit for funds from the social welfare. So if you come in and then you don't have insurance, even as the sister mentioned earlier, if you have health insurance and they are yet to bring it, sometimes you are entitled to 48 hours of care. If they are non-insured, they don't go beyond 24 hours. So what the facility themselves will do is to alert the welfare in the district or the region to assist you. But you can't go to court that, yes, I've exhausted my 8 sessions, but I want more. You can only appeal. You can only appeal by not going through the court, because when you go to the court, what are you going to hold these facilities on? Also look at it, whether it is a private facility or a government facility, because these 8 sessions for dialysis, it doesn't even apply to private institutions as well, except even those who have enrolled on it, they have decided on which cases to take care of and which ones not to accept. So if you are told that insurance do not cater for A, B, C, D, E, going to the court, I don't know what the courts will do in this one, unless there's an appeal for the policy to be expanded to cover other things, like how they said the Muhammad Care is coming to either solely adopt one non-communicable disease and give a comprehensive care, or supplement the health insurance in some aspect. Thank you.
Thank you, Adlan. Okay. Let's take a poll. Paul. If Paul is there.
All right, Doc.
Yeah, Doc. All right, Doc.
Yes, Paul.
Doc, thank you very much, Doc.
Okay.
Doc, just like the dialysis case in South Africa we just discussed, you see, in that case, there is progressivization. So it means that the right to health is more of resource bound. So for me, like making the point that the court should have kind of strict decision on the right to some of these health services may not be the case, because if you look at the grounds, in some cases, you see that the facility itself, the personnel are willing to offer the services, but the resources to use in this service administration may be challenging.
So if we want to bring the court in some of these cases, I think it won't be something that is helpful. So just like the South Africa case that the court made a decision that right to health is progressive legalization, I think in the same direction, the court shouldn't come to some of these matters. Thank you.
Thank you very much. Then we need to move on.
Hello?
Yes. Okay, let's say you are the last one.
Yeah, this is both. I think I have a different view.
All right. Okay.
From the previous lecture, when we talk of health rights, it's to be corrected. We are made to understand that health right does not necessarily mean that clients having right to seek healthcare, but government providing, making it access treatment necessary for their clients. So in that way, if government is responsible to make those things are being provided for clients, and it doesn't exist. And for instance, in Ghana, I think we spend much on things that are not our health as a priority. So if such things government have to provide, and it is not there, and the life of the patient matters, I think the court will always have to intervene to put government so that going forward, those issues can be solved. Just like we talking about the dialysis cases where government said they are going to make it free, but yet other hospitals are refusing to make it free for clients. In that case, we can seek for court intervention to make sure that clients who need those services are given freely for their benefit. Thank you.
Thank you. Good. So we want to touch on something which applies to the practitioners. That's the teaching health professionals to care. And the starting point is that quite apart from the technical competence, which you have, you go to the medical schools, learn the medicine, the pharmacy, the various health allied disciplines. Ethical healthcare requires compassion, empathy, and moral awareness. And these traits certainly are key to professional duty, particularly when we have regards to principles of respect for autonomy and human dignity. So that is a starting point that, yes, we acknowledge that you'll be given all the technical competence, but it's also true that when it comes to healthcare, of course, very soon we'll be discussing the doctor-patient or healthcare professional-patient relationship. And I know we've talked about it. I don't know whether with you. Yes. We look at the various models. Have we done that or not with you? Have we done that? The engineering model, this model, have you done that?
No.
Oh, all right. Okay. All right. So not with you yet. All right. But we do as part of our discussion. So you have the technical knowledge, all right, but it is a reality that healthcare require that you bring compassion to bear on your patient, empathy, and also moral awareness. So the challenges we have in building or cultivating empathy include emotional burnout. Healthcare professionals are exposed to suffering and systemic pressure, so much so that they have what they call compassion fatigue. The way that human beings are, if you see certain things, just like me, like, sitting in court or as a lawyer or whatever, dealing with cases all the time. When a case comes before me, because I'll be seeing it over and over. Or I'm a lawyer, I'll be practicing it over and over. It's not anything, really worrying to me, if I may put it that way, for want of better expression. So in the same vein, healthcare professional who is always, handling cases of patients in pain, patients in serious, condition, their, brain and their heart become so used to it, so much so that over time, they begin to lose sensitivity. And that is what I mean by the compassion fatigue. So that is a challenge. That is a challenge. And again, how to draw a balance between objectivity and empathy. You are a professional, you have the technical competence. But as a clinician, you are also required to maintain professional detachment and at the same time be sensitive to the patient needs. So how do you draw it? That's competing consideration. On the one hand, you are a professional. You are supposed to take your heart, your emotions or feelings from what you're doing and be professional. Make all the necessary technical decisions. At the same time, ethical healthcare requires that you are not a wood, you're a human being. So be sensitive to the case that you are handling. So how do you draw that? And not only in the healthcare profession, we encounter, even those of us in the law, we also encounter that, where you have to remain a professional, fidelity to the law, to your judicial oath. And yet, you're also a human being. You see another human being at the center of a problem. You have to move for the person. So how do you draw that balance between objectivity and empathy? I'm sure you encounter this and you may probably tell me one or two stories. Another challenge in cultivating empathy has to do with cultural sensitivity. Cultural sensitivity. And here, it's important for us to appreciate the social and cultural diversity in the various places in which we apply our trade as healthcare professionals. Those of you who work in the various districts and other places, you will notice that there may be unique, social or cultural context over there from other places that you've been. And when you go there, you have to be sensitive to those things in order to have equitable and ethical care. Now, if you look at the literature, such as the work by Newman and others, Empathy Decline and its Reason, a systematic review, they remind us that there is a research which supports the notion that empathy can be developed through structured education and reflective practice. So I want to find out from you, can empathy be effectively taught, or is it primarily innate? In other words, through your training, your education, can we teach you to be empathetic? Or you think that there are some people who can just not be taught to be empathetic, but for them, they were born. It comes naturally to them. Must empathy be said that you either have it, it's inborn, or you don't have it, or it's something that you can cultivate? Yes, I want us to add the second one too, so that we take it together, so that when we finish, we know that we are finished. Then the other related is, should empathy be evaluated as a component of professional competence? So, for example, they have this thing which has come up, fitness to practice, isn't it? The healthcare professionals. And you are supposed to go through that periodically, including accumulating CPD, continuous professional development, and so on. Or even when you have finished your education in the medical school or healthcare institutions, and you are going to be certified, should our assessment of your readiness to be certified or licensed to practice this profession, must it include an investigation as whether you are empathetic or not, whether you have developed empathy? Should it be part of it? And then finally, how can institution prevent burnout, professionals being given too many cases to handle, so much so that they become insensitive and are unable to show empathy? Yes. What do you think? I need 2 students to speak to this. Yes, let's take Abdullah first. And after Abdullah, Nana. Yes, so Abdullah first, then Nana second, and then probably third, Apekenu, and then fourth, Adeline. But I want you to be straightforward to the point. Don't spend more than a minute in your responses. Thank you. Yes, Abdullah, yes, let's hear you. Let's follow the order I announced. Hello, Abdullah. Okay, he's not ready, so let's take another person. Nana.
Hello, good evening.
Good evening.
So I understand empathy to be the ability to understand and associate with how other people are feeling. So in my opinion, I think empathy is both innate, as in it's sort of born, we are born with it, and also can be learned, because I feel we are a makeup of both our personality traits plus plus environmental factors. So along life's journey, the various experiences we get, the interactions one encounters moves our empathy. So though we may have the foundation being like born with, along life journey and through maturity, we are able to also learn how to exhibit empathy. And about health professionals being assessed with empathy in their line of profession. In my personal opinion, I think it's important, because with the health profession, you may know the theory or have all the knowledge, but some your actions may come from that place of understanding what is actually going on, being able to feel how the people are feeling, because beyond prescriptions and causes of illnesses and all that, we encounter situations like breaking news of someone passing to family. And if you don't have any empathy, the way you go about it might be worse and cause more damage than already is at hand. So that's my opinion about the empathy.
Right, thank you. Next person.
Yeah, thank you, Doc. Please, Apikenu. Yes, so I think as professionals, we are always guided by the ethics, autonomy, non-maleficence, and all those. And sometimes you have to be empathetic to feel for the person, because what you know as a professional, the client may not be aware. The kind of training that we have gone through, they may. So in as much as they have their right, we should always put ourselves in their shoes to feel what they are feeling. Even if it's no matter how lengthy it is, talk to the client and it should come. If it's not natural, if it's not innate, it should come to you throughout your professional journey so that you understand the person. Some may be a bit resistive, but then if you put yourself into their shoes, you're able to give them the information well, or if you explain things to them, they may understand us. So I think it's a very key attribute that we should all develop. If it's not natural, it's something we can also acquire while we are practicing or applying out. Thank you.
Well, thank you. Yes, the next person. That's it. Move on.
This outline, I also want to talk mainly about what the institutions can do, because whether you are born with you have empathy or not is something that you should exercise in your line of operations. And even those that we tag as most empathetic on the job, they also need constant training and the guidance to it. As to what they can do, the first thing I realize is there should be counseling services provided. I mean, free services provided for staff, because staff burnout is real. Especially during the COVID period and all that, anyone that had been in the emergency will see how the staff suffered. And between 2 years to now, those when we have nurses living for abroad, you can have 6 or 7 critically ill patients that are assigned to one young lady or one young man, who one is in a facility in a town that they don't belong. The person is already going through some emotional stress with their relationship. They come, and then patients and relatives also behave towards. They are managing a case, and the case expires, and they don't even have a holding room. So the next thing is, just do it, call the morgue, let them move the body quickly. You are supposed to put yourself together within that moment, how to break news to the family, and then continue care for those that are alive there. So when there are situations like this, they should have people that are well trained to also take up the aspect of breaking news. And then if there's a nurse in charge of a case and the case expires at that moment, those people should be given at least some few minutes break from work, because the person expires and then you are supposed to live your life like it has happened. What haven't we seen before? So within those moments, the people are crowded with lots of emotions. So it's not about how empathetic the person is. So the next moment, they might even be slow in their service delivery to the next patient.
Adeline, thank you.
That this person is being lazy.
Thank you, Adeline. Yeah, so the other thing we want to touch on has to do with the fidelity. And by fidelity here, we're talking about loyalty and faithfulness to professional obligation, and then your commitments, as well as the patient-provider relationship. So how do you maintain confidentiality and at the same time honor patient preferences and also advocate for patient well-being? So how to strike that critical balance is what we are talking about as a fidelity. And of course, when it comes to confidentiality, we discuss confidentiality as a topic on its own, but we will, at this stage, notice that where you need to keep the confidence of the patient, uphold the principle of confidentiality, you may also come under pressure from external parties like family members. So let's give you a scenario. Let's a scenario like I take my mother, right, to the hospital, and I am the one who's paying the bills. Despite the fact that I'm the one paying the bills, I'm not the one who is the patient. My mother is not a child or a minor. or someone who has lost compos mentis, someone who is not sound. She's sound in mind, but should the doctor, the healthcare team, treating or managing my mother, must they disclose everything about her condition to me? So I am like the center party here, like a family member, as it were. Now, if they did that, are they not compromising their obligation of confidentiality towards the patient? So I want to find out, is fidelity limited by other obligations such as public health reporting requirements? Now, these days, HIV, for example, I'm told it's all over. People, I don't know. There was a time HIV, went down. People were using condoms, and there were a lot of public health education. But these days, I don't know whether HIV/AIDS has actually disappeared. We don't hear much about. Of course, the talk about condom is a difficult subject in the sense that whether we wish that people will abstain and people will not be having careless sexual intercourse here and there, but we need to be realists. The reality is that people don't. So as people don't, should we not put in place precautionary measures to ensure that their risky sexual behavior does not cause a public health crisis, like infecting people with infectious disease and all that. So Ghana AIDS Commission, some years ago, used to be very good and promoting responsible sexual behavior. But these days, I don't see that. But if you follow the social media, you get the stories that people who are infected with HIV and then they just keep about, they're deliberately just spreading it all over. So, assuming you are a healthcare professional and you are managing like a patient, yes, you have fidelity to important ethical precepts like confidentiality. Will you say that there's a limit to that, and maybe one legitimate limit to you not keeping the confidence should be maybe the obligation to honor public health reporting, to disclose certain things? Yes, let me hear one person on this, or one male, one female. Okay, let's continue. Nobody's talking.
Doc.
Yes.
Sir, we're such a good with mentioning our names.
Oh, okay.
So on the issue of disclosure or breaking confidentiality, it depends.
Right.
It depends on the situation. I have managed HIV clients before for quite some time, and sometimes you say you want to limit the disclosure to the partner, to the client, him or herself. But you only have to keep encouraging the person to disclose because they owe that partner a duty of letting them know so they can also test. And then if they are also positive, they can also enroll onto care. But you can't also go out of your way to disclose to the partner. So, but sometimes it gets to a point in time where you have to deduce techniques. Sometimes you have to bring the two partners together, find our own ways and means of even screening both of them together. When it is becoming extreme that you know that at this point the other partner is also suffering the condition, but just that he or she has not gone to test and does not know he has been deprived of care, then you come in to break confidentiality. So it depends on the situation at hand. Then medical team can sit down and agree that at this moment we have to do A or B.
Right. Thank you. Yes. Who else?
No, doctor.
Yes.
Yes, Abusa.
All right.
Yes, I think that to break confidence, the rules are very clear. To disclose confidential information. For instance, you use your mother as an example. You are the expenditure, and then you need to know this condition of your mother. The rule says that if your mother agrees that the condition to be disclosed, then it should be written and signed by the said client before the information should be disclosed to you. If the condition is such that it is endangering the public, then the Mental Health Law Act we read indicates that we can secure the court to allow us disclose that information, because we think that not disclosing that information will endanger the life of the public. So it's indeed two categories. I think that we can break the confidentiality based on the patient's wish and then a court rule. Thank you.
Right, thank you. So for next week, okay, we'll hear after this, we'll hear, okay, let me hear Joyce and then we'll end. Joyce, and I'll make this announcement. Yeah, good evening.
Good evening, Doc. So I agree with them. And sometimes, like someone said, if it's of public health significance, then you have to go ahead and disclose. Otherwise, you can't. Having worked in the HIV clinic, it's really tough sometimes, but you are bound by the rules. And you can only continue to engage whoever is infected to get them to appreciate why they must disclose to their partner, for instance, but you cannot go out of your way to. Thank you.
Thank you. Let's take Elizabeth finally. Okay. All right. So next week, this is what will happen. I've given you assignment, and you are supposed to get this submitted, I think, by a day before, which will be like the Tuesday, if I'm not mistaken, the deadline that I gave you. So next week, what will happen is that I will call some of you randomly, in addition to what you have submitted, to engage you on aspect of the work that I have given you. So hold yourself in readiness for that particular exercise before we move on to next topic. So have a good night. Thank you very much.
Please, is it not made by submission or it's individual?
It's individual. It's individual, please.
Because I didn't make my submission.
Yeah, I called you, but you didn't talk. Yeah.
Okay. Then please.
But if you can make it before so that we'll hear you. Okay, make your submission.
Yes, please. Okay. So I'm coming from the point of view that I nurse patients where this time the confidentiality is not about breaking it to the family, but rather to the patients. I work in a sensitive area, the bench unit, where if I should declare my patient's condition to them, rather it weighs them down. So usually what we rather do is the caregivers, the family support, we speak to them so as to encourage the patients to pick up. So this time around, I'm not breaking the confidentiality of the patients to the family members, but rather I'm breaking it to the family members to help them, to help the patient to pick up in their care.
Right. Thank you very much. Thank you, Doc. So all of you, thank you very much and have a good night.